Hey guys, this is Brighton. We recently talked about allergies, especially medications that we use for allergy like antihistamines, and we talked about Benadryl and new formulations like second generation medications like Zyrtec, Allegra, and things like that, and what is the difference between a first generation versus a second generation. And in general, like when we talk about antihistamines, we classify them into two groups. So there's a first generation and a second generation. First generations, they don't have selectivity. Like they don't know, even though they work on the histamine. And we talked about histamine is released by almost all cells when they're stressed. Histamine is a stress mediator. So every cell releases it, saying that there. And so in that sense, brain cell releases it, nerve cells, and mast cells are the majority of them. And so, but first generation antihistamines would go in and they would block histamine from delivering the message. But the problem with first generation like Benadryl is that they go in and attach to every cell. Like they might attach to serotonin cells or receptors, or they might attach to muscarinic receptors. And if you attach to a muscarinic receptor, that's going to happen is that patients are going to experience effects of, it's going to counteract with that. So they're not selective. That's one thing we noticed. But second generations like Claritin and Allegra are very selective to the histamine receptor. So they block histamine from delivering the message. What is that? So with that, what does that mean? So so the second generation, they don't make it to the brain because they're bulkier. And so that means you're not going to experience sedation. So if you're taking Benadryl or Chloroquine, and the next day you're gonna feel very dizzy or very tired, and so, or you can even go to bed. People take Benadryl to go to sleep, and but second generation has less brain penetration, so if you take Allegra or Claritin, you're not gonna experience that sedation or dizziness side effect. And also we talked about side effects of first generation antihistamines, which is insomnia, dizziness, nervousness, and fatigue. But with second generation, they're really rare. You're not going to experience insomnia, or you're not going to be fatigued, or you're not going to feel dizzy. So that's and also you're not going to experience the dry mouth, blurred vision, urinary retention, and constipation that we talked about with first generation medication. So then what if so we're still talking about antihistamine here, but this is more, if somebody's problem is just around the nose and they really don't need to take any oral therapy, like, if they say that whose only symptoms are in the eye and around the nose, then you might want to consider nasal antihistamine. Or you might consider both of them. Sometimes it's good, you can recommend for patients to take both of them. So we have here agents. So the medications we're going to talk about are these three. And also we're going to mention the eye ones. So this is ophthalmic, but let's talk about the agents for nasal antihistamines. So the medications are, the brand name is Panthenase, and the ingredient in it is olopantadine. And we have Astepro, which is azilistine, and Livostin, which is levocarvastine. So why would we use this? So the idea is that you want to recommend this to patients before they fully have allergies. So before the allergy fully takes over, you can recommend this. If the patient says, hey, my nose is itching, or I'm having a runny nose, or I'm having, that sneezing, somebody sneezing, you can recommend this because they're on the early phase. Histamine is just released. And some adverse side effects of this are, since you're spraying it in the nasal, you're going to experience nasal irritation, of course, and you're going to have dry mouth, and you're going to have headache. Histamine, when you block histamine, you always get dry mouth, headache, and sore throat, and mild epistaxis, abnormal taste, because this is a nasal spray, so you're gonna feel and overall like that aftertaste of it. And so this is really, you recommend this for patients who are not adequately taken care of with oral histamine, or if you feel like two therapies are best, which you can do. You can give an oral, and because this tends to work a little bit quicker, and oral takes the time to go into the system, so you can recommend both. And you want to recommend for patients, whenever they buy the bottle for a spray, you want to make sure to tell them before they spray the first time they open it, let them spray it into the air, prime it, let them prime it, let the patients prime the first one. And avoid spraying into the eyes. Always tell people, avoid. You never know. And so the people who made Panthenase and Aspro, they also wanted to make something for the eye. So if you notice, the active ingredient in Panthenase and panthenol for the eye is really olopantadine. It's the same thing. They just formulated better, because whenever you design something for the eye, it has to be sterile. So they probably took it. And if you look at azelastine, it's the active ingredient in Optivar. At the end of the day, it's all antihistamine. And also you've probably seen brand names like Clear Eyes, Itchy Eyes. They all have this active ingredient called ketofen. So they're all antihistamine. That's what, when you see it in the over-the-counter aisle, you might be overwhelmed, but at the end of the day, they're all antihistamine. And with the eye, some of the things about that, you usually use the ophthalmic drops for allergic conjunctivitis. So it's usually used for allergic conjunctivitis, and overall, it's an accept for people. So again, this is for people who only symptoms are in the eye. If somebody's saying my eyes are itching, my eyes are watery, that's really when you recommend an eye drop. But the adverse effects are the same thing. So you're gonna have bad taste. That's the side effect. You're gonna have burning sensation around the eye, and eye irritation and headache. So let me ask you this question. Which group are these medications, all these antihistamines, are they first generation or second generation antihistamine? The answer is it's hard to tell. You probably felt that, because it's really hard to tell, but they act like a second generation. So they're not first or generation, but they act like second generation. Okay, so we covered now somebody who comes to you and asks for, itching, runny nose, and sneezing and things like that. What if the biggest question we always get asked though is congestion? I'm congested, because the idea is by the time people come to you, they've already passed this part. They congested. The body immune system is on a full-blown assault, so they're most likely gonna be congested. And so now without delay, we'll talk about decongestants. So this medication should sound familiar to you. You've heard SudaFed, SudaFed PE, and we'll talk about them now. So one thing you need to know about decongestants, what is SudaFed is used? Always remember, congestion. It's as easy as that. Just don't complicate it. SudaFed, think congestion. It's not going to do more sneezing, itching. It's more just congestion. It's going to constrict the vessel. And how does it work? It works on the... So let me see if my drawing is really bad, but let me see if I can... So if this is a person... It's terrible, bad. And this is the node. Around the node, there's an alpha-1 receptor. So they work on the alpha-1 receptor. So the alpha-1 adrenergic receptor in the nasal mucosa. And what they do is they constrict the nasal mucosa. So because like we said, when the body needs to recruit more immune cells into that area around the node, it's gonna make it a little bit permeable. So that's what you're gonna feel, that squeezing, and then the buildup of fluid and all that. We don't want all that. Like the body, we're trying to tell the body with a decongestion, and don't freak out, calm down. It's not a big assault. So we constrict those alpha-1 receptors so you can get some relief. And so they work on alpha 1, so that's why they only work on decongestant. And the phenylephrine and ephedrine are the body's most that you're familiar with. And in this case, if there's a phenylephrine, it's SudaFed P. If there's ephedrine, there's SudaFed is the medication. And then we call them sympathomimetic overall. And they come in three forms. This is the oral, and we have the nasal, and we have the ophthalmic, just like anything else. How do you pick between the oral versus the nasal? It's because of two things. One, because of adverse effect, and the second one is which one do you want to act fast? Like, what kind of response do you want? And we'll talk about that now. But let me just tell you about the nasal one. So the nasal one, it's divided into, like I said, timing is very big with decongestants, and you have a short acting and a long acting. With the nasal, so if you want a short acting, it's nafazoline. And remember this, nafazoline is very important. You actually see it a lot in a lot of products, and it's a nasal decongestant. And if you ever seen four-way acting, norepinephrine, they're all phenylephrine based short acting. There is short acting compound. Long acting is afrin, oxymetazoline. And this really matters in terms of like your patients. Like if a patient comes to you and they want something long lasting, or you don't want them to be disappointed where they get a quick relief and then they just go back to normal, you really have to kind of think about, okay, do I want to send them with a nafazoline based product or like Previne, or do I need to send them with Afrin? Like, because that they're gonna come back and tell you, hey, that thing you recommended, it didn't work, So for intranasal, so it's minimally absorbed into the bloodstream, and that comes in very important when we talk about oral, because oral, you're swallowing it, so it's going into the bloodstream. And what is the consequence? One, it's going to take it a little bit longer. Like we talked about any nasal product, it's going to take it a little bit longer. So your patients are not going to, if they're going to work or things like that, they're not going to experience a quick relief. And the other thing too is that if you ever heard of SudaFed, it's usually related to like the control substance, the methamphetamine. So pretty much it has a sense to have a really bad side effect on other part of the body, like the heart. It tends to speed up things, and that's really, or it might keep you awake. And so it's a stimulant. So you might experience things like insomnia, nervousness, anxiety, tremor, fear, dizziness, headache. That's not really a good thing when you're trying to go to work on things like that, because it's just going to keep you a little edgy. So any of the insomnia, tremors, anxiety, fear, headache, and dizziness, or if you have cardiovascular, if the patient has high blood pressure, they have had a stroke before, MI, heart attack before, it's gonna give them tachycardia or increase their heart rate or elevate their blood pressure. And if they have arrhythmia, they're gonna it might kind of trigger a little bit of the rate, or the disturbance. So they're just gonna feel uneasy around their chest. So all because you recommended this medication. So maybe if you're worried about that, you might want to. So that's when it becomes, what's the difference between the two is that they both do the same thing, but because nasal one doesn't get into the bloodstream, your patients are least likely to experience the side effects like we talked about. And so beside that, one thing I wanted to tell is that you always want to recommend these things for, especially the nasal one, 3 to 5 days. So that's very important. Like some people are going to love this. So this is the 3 to 5 days. This one you can give them long term. I've seen it like prescribed long term, so it's not too much. Like for a long